going to talk to you about nutritional management in pre-dialysis, chronic kidney disease, and maintenance dialysis patients. Now, why are we talking about nutritional intervention? Why is it required in chronic kidney disease? The kidneys, we know, are key homeostatic organs. Among their many functions, kidneys maintain body's balance of several minerals like sodium, potassium, phosphorus, and of course, protein is a big host for them. And consequently, patients with chronic kidney disease and end-stage renal disease are prone to uremia-induced hidden conditions, namely the oxidative stress, inflammation, metabolic acidosis, mineral imbalances, which greatly contribute to morbidity and mortality. Now, the term renal disease embraces a number of clinical conditions whose common feature is loss of kidney function, development of cardiovascular disease, and another common feature that these conditions share is malnutrition. Now, we know that kidney disease has 5 different stages depending upon the declining GFR. And well, it is chronic kidney disease is defined as kidney damage for more than 3 months. So more than 3 months is the key thing here, as defined by structural or functional abnormalities of the kidney with or without decreased GFR. Now, high blood pressure is not included in the definition of chronic kidney disease or its stages, but is a common cause or a consequence of chronic kidney disease. Similarly, proteinuria is an early and a sensitive marker of kidney damage in many types of chronic kidney disease, and that is also a reason for malnutrition in our patients. Now, if you have a look at this figure is showing you the etiology of protein energy wasting in CKD. That is PEW, protein energy wasting, is the term that the nephrologists use for malnutrition. It's been cachexia and all those terms have been replaced simply by protein energy wasting because malnutrition is basically of 2 types. Type 1 is something which is reversible, which does not have inflammation, but type 2 is not reversible, which is what we see in our patients because it has a very important component, that is inflammation, which is the most ignored part in our practice. So protein energy wasting is described as loss of protein, body protein mass and fuel reserves. So if you have a look at this figure is showing you because of uremia, the hormones, leptins are increased in levels, the ghrelin levels are reduced, and the tryptophan and serotonin are totally disoriented. And therefore, this leads to anorexia, and therefore decreased hunger causes decreased intake of calories because the patient doesn't eat very well. Let me remove this from here. Okay. Let me remove this thing from here. How do I remove it? I don't want this. Yeah, okay. And then these patients have retention of middle molecules and uremic compounds. And then on top of that, the metabolic acidosis ensues, which causes accelerated protein catabolism, leading to loss of lean body mass. And then there's increasing inflammation, which is so very hidden, which leads to increase in acute phase reactant proteins and leads to reduced protein synthesis and hypoalbuminemia. And then on top of that, intercurrent illness. And the whole scenario here is leading to increased morbidity and mortality in our patients. On top of that, because the renal function is impaired, there's impaired clearance of pro-inflammatory cytokines and increased levels of pro-inflammatory cytokines. Then, of course, as I said, the superimposed illness, accumulation of uremic toxin, increased resting energy expenditure, reduced energy intake, and then the mitochondrial dysfunction is definitely there. There's increased free radical production, and then on top of that, impaired signaling of insulin and IGF-1. I'm going to talk to you about this, and then eventually the patient is coming on to renal replacement therapy, and then the patient is eventually getting catabolic day by day. He's getting cachexic, and we're not really working hard towards not letting this happen, and then he becomes physically frail, and so all these things happen. So once chronic kidney disease sets in, the vicious cycle of catabolism caused by uremia-induced anorexia, inflammation, metabolic acidosis, malnutrition, frailty, depression, infection, anemia, fluid imbalance, and hormonal imbalance begins, which leads to loss of lean body mass. So surveillance of nutritional status for good nutritional outcome is very important. And if you have a look at this figure is showing you the catabolic pathways which cause protein loss in our patients, that is the muscle wasting, declining nutritional status in CKD. So what happens is, because of uremia, the patient is not able to eat very well. So there is reduced dietary and amino acid intake, which means that there's a small amino acid pool available for protein synthesis. And then on top of that, the leptin levels are increased, the ghrelin levels are reduced, the vitamin D levels are reduced, the IGF-1 axis is impaired, the growth hormone axis is impaired, which leads to, and again, it is causing inflammatory cytokines, increased angiotensin 2, aldosterone levels are increased, cortisol levels are increased. So here what is happening is all these things cause reduced insulin sensitivity, increased insulin resistance, and hence the whole thing is affecting protein synthesis and eventually leading to more of protein breakdown because of all these conditions. And eventually the net effect is protein loss, muscle wasting, and reduction in the nutritional status. Now, chronic kidney disease is a catabolic state associated with protein energy wasting, decreased muscle synthesis, and multiple metabolic derangements due to uremia. So in CKD, sarcopenia includes any loss of muscle mass and function due to age or chronic illness, reduced physical activity, low protein energy intake, and physical inactivity. But regardless of the initiating factor, the loss of muscle mass in CKD is attributed to a negative balance of protein homeostasis. Now, if you have a look at this figure, this is an elegant experiment in early 1990s by Dr. Ikiza, which is showing you that as renal function declines, as this is the GFR here, creatinine clearance, as the renal function declines, there's spontaneous reduction in the dietary protein intake. And here, the biggest study so far in the history of nephrology, that's the MDRD study, has shown that there is an association between dietary intake and the GFR. So here, as the GFR declines below 60 ml per minute, there is a reduced protein energy intake and reduced levels of albumin ensue. So undernutrition causes muscle protein loss and is the key contributor to the development of sarcopenia and frailty in CKD, which affects the nutritional status. So deterioration of clinical nutritional status is characterized by progressive weight loss, wasting of fat and skeletal muscle tissues, and reduction of serum proteins. Here, I should have, if I had spoken to you about this on Wednesday, I would have told you what is an SG score, how do you do the screening, but anyway, I'll take it up, maybe just for 10 minutes, I'll take a class then that day also. Now, when does protein energy wasting set in? Protein energy wasting most likely occurs during CKD stages 3 or even earlier because of inadequate nutritional management in the pre-dialysis phase, and it becomes clinically evident when GFR is less than 15 to 10 ml per minute. And you know that 20 to 70% of patients on maintenance hemodialysis or maintenance dialysis show signs of protein energy wasting. So why do we need to modify the diets? What happens is, as kidney disease progresses, the capacity to respond to changes in intake of nutrients and water becomes less flexible. Solute and water excretion per nephron increases, but the fewer number of functional nephrons leads to a more restricted range of solute and water excretion. And therefore, when diet exceeds daily protein requirement, the excess protein is degraded to urea and other nitrogenous waste, and these waste products accumulate in the body, causing uremia. Here, there is loss of nephron mass, and here this is excessive protein intakes. So therefore, the severity of uremic syndrome is proportional to the accumulation of waste products. So we need to modify diets of these patients. Now, in kidney failure, nutritional therapy allows a very good control of several consequences of the disease, like nausea, vomiting, anorexia, and can even delay initiation of dialysis. So pathophysiology of CKD necessitates pharmacological and nutritional intervention. Now, the pathophysiology of CKD involves two important mechanisms. One is initial mechanism of the specific underlying etiology, and two, a series of progressive mechanisms involving hyperfiltration, hypertrophy of remaining very viable nephrons due to a long-term decrease in renal mass. So two factors which explain progression of CKD are hemodynamic and non-hemodynamic factors. I'm not going into the details of this. Well, eventually what is happening is the persistent glomerular injury is going to disrupt adjacent, is going to cause fibrosis and scar formation. And the non-hemodynamic factors which play a role in the progression of CKD are the angiotensin 2, the aldosterone, the endothelium, the acidosis, and the oxidative stress, which worsens progression of CKD. So malnutrition is an additional factor which causes increased oxidative stress in these patients. So protein energy wasting is amongst the strongest predictors of mortality in CKD patients. Based on ISRN classification, this is International Society of Renal Nutrition and Metabolism, which has coined the term protein energy wasting. So we are no more using the term cachexia or sarcopenia, we are using protein energy wasting. So this is, according to this classification, the prevalence of protein energy wasting increases as renal function declines from less than 2% in CKD stages 1 to 2 to 11 to 54%, or even up to 70% in CKD stages 3 to 5. And in patients undergoing maintenance dialysis, prevalence of protein energy wasting is between 28 to 54%. Now, if you have a look at this table is showing you the CKD Registry of India, which has shown that as the CKD stage advances, the BMI decreases. That is, the patient is losing weight, is losing muscle mass. In our patients, remember one thing, the patients, the fat is not mobilized fast. It is the lean body mass which is mobilized due to various factors, inflammation, causing protein catabolism, the serum proteins going down, and there's always a signal going to the muscles, oh, break, because the plasma proteins are going down. So we need we need to get into the normal state. So mortality is related to muscle mass in CKD disease. And this association leads us to two important questions. How are the protein stores lost, and how can the losses be prevented? So I'm not going to get into these mechanisms because I really don't have time. The loss of muscle protein stores results from three responses. One is impaired growth of new muscle fibers. Two is suppression of protein synthesis, and three is the stimulation of protein degradation. So muscle wasting in CKD begins with impaired IGF-1 signaling, causing abnormal protein metabolism, reduced satellite cell function, which contributes to atrophy. And this, it's very my favorite figure, which is showing you what happens in normal muscle growth and how CKD really impairs muscle growth. So it's the MyoD, which is the master switch of satellite cell activation, which is actually decreased. So there's a decreased expression of MyoD, the master switch of satellite cell activation, which causes reduced differentiation of isolated satellite cells from CKD mice, which causes lower number of embryonic myogenic heavy chain cells, and this leads to lesser and suppressed myotubule formation compared with controlled mice. And CKD delays the regeneration of injured muscles and decreased MyoD and RNA and myogenin expression. So in short, CKD suppresses satellite cell activation and differentiation, impairs proliferation and differentiation of satellite cells, and muscle regeneration is decreased. And so here you can see this slow muscle regeneration, there's increased collagen deposition leading to fibrosis and increased TGF-beta1 mRNA, which are all actually destroying the muscles. So, and the second potential mechanism causing muscle wasting is CKD-induced suppression of protein synthesis. Compared to healthy individuals, experiments have shown that patients with CKD have 27% lower rate of synthesis of mixed muscle protein and 37% lower rate of synthesis of myosin. And this is the most important mechanism, the third major mechanism which degrades proteins. You must all be knowing about it, I'm sure, is the ubiquitin proteasome system, which actually is responsible for the protein degradation in our patients. So, and actually this work got the discoverers the Nobel Prize of 2004. Now, uremic toxins exert an inhibitory or a pro-apoptotic effect on immune cells and contribute to activation and priming or anti-apoptotic effects, giving rise to inflammation. So here you can see immune cells, and this is everything is going to happen. Infection will happen, and the anti-apoptotic effect and the baseline activation and priming, this is going to lead to inflammation. and all because of uremic toxins. Now, CKD is characterized by a persistent low-grade inflammation, and inflammation is directly related to CKD progression. The chronic inflammation is therefore a major culprit in muscle wasting, and we are actually not treating our patients for inflammation. Otherwise, we can really control this loss of muscle mass in our patients. So early intervention to control inflammation can check malnutrition. Now, oxidative stress and inflammation cause CVD, infection, and catabolism in our patients. In uremia, diminished immune defense system contributes to the high prevalence of infections, whereas pre-activation priming of immune cells, as I just mentioned previously, leads to inflammation and consequently to the CVD. And now, how can the losses of muscle mass be prevented? Now we're talking about intervention. Well, the first thing I always say is control inflammation, which we are really not doing. So in order to optimize the response to any specific drug therapy for muscle wasting disease, it is important to first diagnose and stabilize the clinical condition of the patient, provide adequate nutrition, provide an adequate level of exercise, and control inflammation. Okay, so there is a gap between the goals of healthcare team and the patient in the chronic kidney disease. So chronic diseases require adaptation to lifestyle, adaptation to a new situation where whether good or bad involves acceptance. So patient has to accept it. To achieve health goals, behavioral changes are the prerequisite. And the three most widely studied interventions linked to effects on GFR for slowing progression of CKD are lowering of blood pressure, proteinuria reduction, and antihypertensive drugs. So I'm not getting into this. Metabolic changes impact nutritional status. We all know there is effect on the glucose metabolism, protein catabolism, and abnormal lipid metabolism in our patients. Now, in early CKD stages, renal specific diets help protect kidneys from further damage. So current guidelines for CKD management recommend dietary and lifestyle modifications in our patients. So what are specific nutritional requirements of our CKD patients? We know that excessive protein intake when nephron mass is reduced causes damage to remaining nephrons. Increase in single nephron GFR and increased glomerular capillary and transcapillary pressure affects renal mass reduction. After renal mass reduction is a cause of accelerated glomerular injury. So dietary protein has an independent therapeutic effect. We know that dietary protein causes postprandial hyperfiltration, induces or increases proteinuria, leads to glomerulosclerosis and renal insufficiency. So low protein intake when the patient is not on dialysis lowers hyperfiltration, retards onset of proteinuria and glomerulofibrosis. So if you have a look at this figure, it's a beautiful paper by Kalantazadeh. In this is very clearly shown that low protein diet has independent therapeutic effect in the sense that low protein diet causes vasoconstriction of the afferent arterioles and vasodilation of efferent arterioles, thereby reducing intraglomerular hypertension, thus preventing decline in renal function through angiotensin modulation. So so the potential advantage of low protein diet is that it decreases uremic symptoms, improves phosphorus control, because hyperphosphatemia is a major comorbidity in our patients, delays the initiation of dialysis, does not increase the risk of protein malnutrition if combined with essential amino acid supplementation, and protects against oxidative stress, which may aggravate progression of CKD. So one has to remember that when you're giving a low protein diet to a patient, it is actually you're pushing your patient towards energy malnutrition, which means more of a muscle loss. So you have to ensure that your patient gets enough energy intake, and your dietitian is going to help you with this. So so therefore, one has to correct signs and symptoms and complication of chronic renal failure, reduce uremic toxicity, decrease proteinuria, maintain good nutritional status, lower the risk of kidney disease-related secondary complications, and slow the rate of progression of kidney failure to ESRD, and delay initiation of dialysis. That is what is the main aim of nutritional intervention in our patients, along with what you give as ACE inhibitors or ARBs, trying to prevent damage through accelerated hypertension or uncontrolled diabetes and all those things. So in pre-dialysis stages, CKD stage 2 to 5 non-dialysis, protein-restricted diets may result in essential amino acids deficiency and thus deteriorate the patient's nutritional status. So therefore, supplement your patients with keto analogs. I'll show you, they are excellent. They work wonderfully well with our patients. Now, when we talk of supplementing our patients with keto analogs, we're talking about very low protein diet. very low protein diet. When it began as 0.3 grams per kg body weight per day, along with 1 tablet of keto analog per 5 kilograms body weight. But now things have changed, and so the concept has increased from 0.3 to 0.4 to 0.5 grams per kg body weight per day of protein in a very low protein diet, along with 1 keto analog tablet for every 10 kilograms of body weight to prevent uremic symptoms, delay time to dialysis, and lower phosphates. But ensure, as I mentioned earlier also, they give them a high energy intake, and do check for calcium levels routinely to prevent hypercalcemia whenever you're supplementing your patients with keto analogs. So this is a study that we did here in our department, which has shown that this is the intervention group, that is the keto analog group, and this is the control group. And what we saw that in the intervention group, the decline in GFR or rise in creatinine was much, much slower than compared to patients who were in the control group here. And as you can see here, that there was faster decline in renal function into ESR in control groups compared to our treatment group here. Okay, so, and also the major advantage here is that the proteinuria is reduced by the end of the study. The metabolic acidosis improved. We had better control of phosphates. We had better control of insulin sensitivity. There was improvement in insulin sensitivity. The HDL cholesterol went up, and the triglycerides came down. So in CKD patients, proteinuria is the strongest correlate of arterial hypertension, particularly of increased nocturnal blood pressure rise, possibly as an expression of vascular damage. So low protein intake lowers hyperfiltration and retards onset of proteinuria and glomerulofibrosis. And here you can see in this figure that very low protein diet with high quality of fruit and vegetables, and with a low amount of protein supplemented with essential amino acids and keto logs of non-essential amino acids considerably reduces net endogenous acid production by 53% after 6 months and 67% after 12 months, and potential renal acid load by 120% after 6 months of the study. So correction of hyperpotasemia as a consequence of physiological correction of metabolic acidosis was observed after 12 months on very low protein diet. Now, the source of protein has a very independent therapeutic effect. The plant-based diets contain low amounts of protein. They are rich in potassium and phosphorus, but only 40% of phosphorus is absorbed because the human beings do not express the enzyme called phytase. Therefore, whatever phosphorus is available from the plant protein, only 40% is absorbed, whilst if you give animal protein, 80% of the animal protein will be absorbed. So plant protein is always preferred over animal protein in our patients. And they are believed to be, the plant diets, when you talk of them, they're believed to be unsuitable for CKD patients because of high potassium content, but you can always take care of. You can choose fruits and vegetables which are low in potassium. However, if vegetarian diet is used wisely, it delays transition from one CKD stage to another. Now, this is a beautiful paper, Vegetarian Diet in Chronic Kidney Disease, a friend or a foe. I would say it's a vegetarian diet is a natural source of prebiotics. Vegetarian diet might potentially reduce uremic toxins like indoxyl sulfate and precasol production by the intestinal microbiome, and levels of indoxyl sulfate and precasol sulfates are lower in vegetarian patients undergoing hemodiafiltration compared to patients who are having animal protein. And they also generate low serum urea, and of course, the patient has low serum phosphorus levels. Now, plant protein, therefore, should be preferred over animal protein because there's 20% less proteinuria in soya-based diets. These studies have shown, and fibrosis is lowest, that is 20% in soya group compared to casein group, that is 45% in the casein group. Therefore, reduced animal protein intake reduces glomerular hypertension. And here you can see in this figure that with animal protein load, the GFR and the renal plasma flow increases compared to the soya protein load. And when you combine ACE inhibitors and ARBs, you know that ACE inhibitors and ARBs reduce the degree of proteinuria in renal disease. But when you combine them with low protein diet, an additional antiproteinuric effect is observed in the patients. So low protein diet should be supplemented with calorie dense and low protein supplements. Yes, and this study has shown that in the control group on low protein diet, that is 0.6 grams, and the supplemented group, when they were compared. Hello? Is anybody saying anything to me? All right, so I'll continue with my talk. Supplemental group on a low protein diet and hypocaloric supplements had the better preserved nutritional parameters, and they had less marked decrease in renal function. And also an effective strategy to enhance the salutary effect of low protein diet is to assure at least 60% of the protein that you give to your patients is of high biological value. You must provide adequate energy, that is 30 to 35 kilocalories, to prevent malnutrition. And these are the foods of high biological value. The milk and milk products and the soy products are really very good. And remember that the phosphorus, don't be scared of the phosphorus content of the soy products. They will not be absorbed completely. Only 40% of them will be absorbed. And well, meat products are high in phosphorus. So if you have a look at this table is showing you what is the actual guidelines for our patients. The low protein diet, the second row, is 0.55 to 0.6 grams per kg body weight per day of protein. And however, if the patient is not able to accept such a low protein, then you can increase it to 0.75 grams. But the latest guidelines are encouraging use of 0.55 grams to 0.6 grams per kg body weight per day of protein. And very low protein, as I mentioned, is 0.3 to 0.4 or 0.5 grams per kg body weight per day. I've already spoken about it. Diabetics, the diabetic patient should be initiated on 0.8 grams per kg body weight per day of protein, which should be reduced to 0.6 grams per kg body weight per day as GFR starts declining. And the energy intake in diabetics should be 25 kilocalories to start with. But if required, you can increase it up to 30 kilocalories per kg body weight per day so that their sugars are, well maintained. In children, patients who have nephrotic syndrome, the protein intake is 0.8 grams per kg body weight. But actually in children, you do not restrict protein at all because everything is done according to the recommended dietary allowances. But in adults, it is again 0.6 to 0.8 grams per kg body weight per day for at least, and with 1 gram for each gram of albumin lost, you add 1 gram of protein to each gram of albumin lost in the urine. Soy protein are beneficial for our patients because they are rich in branched chain amino acids. Protein intake according to RDA for chronological age should be the rule of the thumb whenever you're practicing or treating a child. Restrict fluid in a nephrotic patient, of course, I'm going to talk about it later. But whenever the patient, even in chronic kidney disease, who is not on dialysis, whenever the patient has acute illness, please do increase the protein intake to 1 gram per kg body weight per day, because these patients become hypercatabolic. So therefore, in order to preserve nutritional status, as long as the patient is not vomiting or is not having too many uremic symptoms, you can increase the protein intake. And energy intake is according to years. If the patient is above the age of 60 years, we consider them to be not very mobile. They're more sedentary. So the energy intake should be 30 kilocalories per kg body weight per day. However, the patient is less than 60 years of age, then the energy intake is more than 35 kilocalories. It's more between 30 to 35 kilocalories. And the visible fat that you have to give to your patients is between 50 to 20 grams, which is, you can give them a combination of peanut oil with mustard oil, rice bran oil, or sunflower oil. And as Dr. Sudeep was mentioning, I'm not going to talk about the Mediterranean diet. I'll just show you one slide. I knew he was going to cover it up. Olive oil is an excellent replacement because it is rich in monounsaturated fatty acids. And you know that in the Mediterranean area they use a lot of olive oil, and these patients do not have such a high incidence of hypertension. And so and 30% of the calories should come from fat, and the dietary cholesterol should be reduced to less than 200 milligrams daily. Along with, you can supplement them with the omega-3 fatty acids. Sodium intake should be less than 2.4 grams per day. I'm going to talk about sodium later on, and I'm going to talk about potassium also. The intake should be less than 1 milliequal per kg body weight per day. Calcium should not exceed 2000 milligrams per day. And if the patient is on vitamin D analogs, do prefer bringing down the dietary and the supplemental calcium to between 1200 to 1500 milligrams per day. Now, anemia cannot be corrected through diet, so correct iron profile of the patients and supplement them vitamin B12, folic acid, and iron, and EPO. Of course, you have to give this to the patients. And well, we know that metabolic acidosis plays an important role in the pathogenesis of nutritional abnormalities associated with uremia because of metabolic acidosis, there is increased activity of branched amino acids, branch chain keto acid dehydrogenate, and increased activity of caspase 3. And then there's insulin resistance. Along with that, there's inflammation and reduced serum leptin levels. And the whole thing then leads to protein energy malnutrition in our patients. So pre-dialysis stabilized serum bicarbonate should be maintained at 22 milliequals per liter in chronic kidney disease stages 3, 4, and 5. And the serum levels of total carbon dioxide should also be maintained at 22 milliequals per liter. And here you can see in this figure that when you supplement your patients with sodium bicarbonate, there is improvement in metabolic acidosis and improvement in the nutritional status of the patients. And for preservation of renal function, advise antiproteinuric omega-3 fatty acids. As you do, the recommendations are DOQI guidelines do recommend use of omega-3 fatty acids in IgA nephropathy, if even despite use of ACE and ARBs and all antiproteinuric treatments, the patient is not responding, then to control proteinuria, you can add omega-3 fatty acids. Now, AHA recommends, which Dr. Sudeep has already very nicely covered. He's covered all these things. Food sources for omega-3 fatty acids are fish, flax seeds, and flaxseed oil, canola oil, soybean oil, and nuts. At least 2 servings of fish per week, particularly for our patients on dialysis, because in the pre-dialysis patients, we are really worried about giving them protein from the animal source, because we are scared of the hydrogen ion overload. So we do not want them to get into metabolic acidosis. We do give them soda bicarb, but we want to prevent metabolic acidosis from setting in. So we discourage our patients to taking, plenty excess of, not even excess, a lot of fish and chicken routinely. We prefer them to maintain them on vegetable or protein of vegetable origin. Now, I've already spoken to you about fats. Limit intake of saturated fats to less than 10%, trans fatty acids to less than 1%, and substitute grains and unsaturated fatty acids with fish, vegetables, legumes, and nuts. Diets enriched in unsaturated fatty acids rather than carbohydrates benefit in modulating the atherogenic dyslipidemia. So this study has shown, this is the OmniHeart trial, they've shown that carbohydrates are partially replaced by, when carbohydrates are partially replaced by fat, unsaturated monounsaturated fats, it lowers blood pressure, triglycerides, and increases HDL cholesterol. So the component of diet which really helps reduce dyslipidemia are the plant sterols, that is, the source is soybean butter or the margarine, and this also improves the glycemic control. And so you can think of giving 2 grams of plant sterols to your patients through soybean butter or margarine in 2 to 3 divided doses. Reduce dietary cholesterol, I've already mentioned. Restrict full fat dairy products and tropical oils like palm oil, coconut oil, and palm kernel oil. And say big no to bakery products, because these contain a lot of hidden saturated and trans fatty acids. Dr. Sudeep has already covered this. And stop reuse of oil, which you did ask him for frying and all, and restrict eating out in restaurants. Include soluble fiber in the diet to reduce total and LDL cholesterol. And a very good source of soluble fiber is bhindi. Bhindi is very, very advantageous for our patients. And then gorgum, that is gohar pali, is very, very good source of soluble fiber, because every gram increase in soluble fiber decreases LDL cholesterol by an average of 2.2 milligrams per deciliter. So fiber intake should be between 25 grams, and it can be increased up to 35 grams per day for our patients. Now, hypertension, everything Dr. Sudeep has already covered. I'm just going to talk about step 1 and step 2 diets are widely recommended for as the first line for CVD intervention for lowering blood cholesterol levels. Now, the JNC and the National Committee on Prevention and Detection and Evaluation and Treatment of High Blood Pressure and all, they recommend non-pharmacological interventions such as diet, weight loss, and physical activity for primary and secondary prevention of hypertension. And for a CKD patient, the sodium intake should be reduced to less than 2 grams per day for better control of blood pressure and edema. And JNC 7 recommends less than 1.5 grams of sodium per day, a reduced intake of salty processed food, cheese, and meat. And modification of lifestyle is very, very important. Our patients are depressed, they tend to be more sedentary. So at least 40 minutes of walk at least 5 times a day is something that the patient should do. And salt intake, and if you have a look at this figure, it's showing you that salt intake has a direct correlation with proteinuria and edema. So therefore, patients must avoid canned foods, fruits, pickles, fruit jam, because they contain salt as preservative. In CKD patients, proteinuria is the strongest correlate of arterial hypertension and particularly of increased nocturnal blood pressure, which I've already said before, possibly as an expression of vascular damage. So one has to control blood pressure. Well, Dr. Sudeep has covered Mediterranean diet, but I am not asking you to prescribe Mediterranean diet to our patients because it is very, very rich in fruits and vegetables. The only reason I'm going to talk about this is because of the Sun study, and has shown that olive oil is very, very cardioprotective. The olive oil has vasoprotective effect of polyphenols, which increase the endothelial synthesis of nitric oxide and has protective role on both systolic and diastolic blood pressure. This is how a Mediterranean diet looks like. But so for our patients, you can pick up fruits which are low in potassium. I'll tell you right now. Vegetables which are low in potassium. Bread and cereal, well, you have to give, but you have to give them refined bread. And because we are worried about a comorbidity, that is hyperphosphatemia. So we do not want our patients to go into a CKD MBD, that is mineral bone disease. So we have to prevent hyperphosphatemia at any cost. Olive oil you can use, or you can use mustard oil, which is also very rich in monounsaturated fatty acids. And then, of course, eggs you can always prescribe to your patients. We're going to talk about it later. So, well, Mediterranean diet assures an adequate intake of beta-carotene, vitamin C, tocopherols, and linoleic acid. And it is really, really, really very good, but not meant for our patients. Now, moving on to hyperkalemia, well, we have to prescribe a low potassium diet if the serum potassium is more than 5 milligrams per deciliter, and potassium intake should be less than 1 milliequal per kg body weight per day for our patients. Remember that 1 gram of protein brings you 1 milliequal of potassium. So you can easily calculate, if you're giving 30 grams of protein to your patient, you have straight away given them 30 milliequals of potassium. And on top of that, when you give them fruits and when you give them other things and vegetables, then that is again going to contribute to the potassium intake, so that your dietitian can very well calculate for you how much vegetables, how much potassium the vegetables are contributing towards the diet. So you have to restrict green leafy vegetables, tomatoes, sweet lime, lemon, carrots, raw salad, mango, dry fruits, fruit juices, watermelon, vegetable soups, and coconut water in our patients. And also remember that you can reduce potassium content of the vegetables by leaching or removing potassium from vegetables by boiling or soaking chopped vegetables in lukewarm water for half an hour. But presently, there's no consensus on this, because studies are showing that you really have to work hard to leach potassium. So it's better that you keep your patient on a low potassium diet through, not asking them to leach them, but by giving them low vegetables and low potassium vegetables and fruits. Now, moving on to hyperphosphatemia, patients with renal impairment progressively lose ability to excrete phosphorus. Hyperphosphatemia is a strong predictor of mortality in advanced CKD stages. Therefore, restrict phosphorus to between 800 to 1,000 milligrams per day. Advise low protein diet in pre-dialysis patients with low phosphorus content, and supplement with ketone logs to maintain nutritional status. Use phosphorus. This is a phosphorus pyramid. You can choose it. It is available on the internet, and you can choose foods of low phosphorus content and advise foods containing low phosphorus to protein ratio, because studies have shown here that there is a twofold increase risk of death in patients on maintenance hemodialysis who take foods with very high phosphorus to protein ratio foods. So there, here you can see if they're taking something like 20 or 16 ratio of phosphorus to protein, then the likelihood of the death of risk, the risk of death increases. So these are the things one has to avoid. Anything that contains chilka is rich in phosphorus. So dals with chilka, the pulses or the lentils with chilka, they have high content of phosphorus. So you must tell patients to take duli dals or dals without chilka. All right. And of course, they can take kidney beans and chickpeas once a week. That is all right, because these are soaked overnight. And so a lot of potassium is leached, and then they are cooked for a long period of time. And so phosphorus happens to be heat labile. Therefore, a lot of phosphorus is also killed. Now, remove choker from atta. As I said, you have to give them refined bread to the patient, that is refined bread or chapatis. You can't give them whole grain bread. So because choker is the chilka, and it is very high in phosphorus. And the sources of plant foods as dietary phosphorus are basically the legumes, the nuts, and the chocolates, along with inorganic phosphorus in the form of food additives. And remember, the good news is that egg white has one of the lowest phosphorus protein ratio and is also devoid of cholesterol. So it's a boon for our patients, and it's a food of high biological value. So you should prescribe more of egg white to our patients. The highest dose of phosphorus comes from protein-rich foods, that is nuts, hard cheeses, egg yolk, meat, poultry, and fish. So you should avoid giving these to your patients, and avoid foods with phosphorus-based additives like cola beverages, enhanced or restructured meat, frozen meals, cereals, snack bars, processed or spreadable cheeses, instant products, refrigerated bakery products. And this is a table which I am also not able to read, so I can't expect you to read, but this table is showing you the variety of foods with different kinds of, with different levels of protein to phosphorus ratio. And here, remember, if your patient has residual renal function, then the requirement of phosphate binder is definitely low compared to a patient who is anuric. So try and preserve, the residual renal function of the patients, and advise phosphate binders with meals. Protein, has a linear relationship with phosphorus. So as you increase the intake of protein, the phosphorus intake also goes up. 1 gram of phosphorus protein contains 13 to 15 milligrams of phosphorus. So you can actually calculate, if you're giving 30 grams of phosphorus, just multiply it by either 13 or 14 or 15, and you will have a true estimate of how much phosphorus you're giving to your patient. Okay. And high phosphorus is a risk for the development and progression of cardiovascular disease and mineral bone disease, about which we are so scared. And eventually, we don't lose our patient because of the kidney disease. We lose the patient because of this thing, the cardiovascular disease. Okay, and how can dialysis be of help in controlling phosphorus? Well, we know that 1 day of peritoneal dialysis clears between 300 to 400 milligrams of phosphates, and 1 regular hemodialysis can very easily clear between 500 to 800 milligrams of phosphate. Yet phosphate binders are a must, because the patients are, I'm not talking about the PD patients, but I'm talking about the hemodialysis patients who are not on daily dialysis. They are either on a twice weekly or a thrice weekly dialysis. So they are always in a positive balance for phosphates. So they have to be on phosphate binders. And as I mentioned, that boiling reduces phosphorus contents with a negligible loss of nitrogen, leading to a more favorable phosphorus to protein ratio food for them. And here, I'm going to talk about just a small bit about the nephrotic syndrome. This is a paper which is talking about effect of combined gluten-free, dairy-free diet in children with steroid-resistant nephrotic syndrome. Here we know that idiopathic nephrotic syndrome is the most common type of nephrotic syndrome in children, presenting clinically with massive proteinuria, hypoalbuminemia, hyperlipidemia, and edema. Now, without response to steroids and therefore persistent proteinuria, the steroid-resistant nephrotic syndrome poses an enormous therapeutic challenge. And so therefore, if you can give them a gluten-free diet, and or if you can keep them away from dairy foods for some time, for a month or 2 or 3, then you will see that proteinuria will start resolving. Exposure to sensitive foods. I just compiled the slides now, so they are not looking very beautiful, but anyways, I'm trying to give you the message here. The exposure to sensitive foods may trigger the release of inflammatory factors, the cytokines that could directly damage the podocytes. And here in nephrotic syndrome, we are talking about the effacement of podocytes, and we are so worried about it. So you have to do something about it. And therefore, there's several papers now on elimination diet. And it's actually called elimination diet, where you start eliminating one food after another, and you see a wonderful, wonderful result in these patients. So, so for a successful treatment of nephrotic syndrome with hypoallergenic diet has long been documented in several clinical studies and case reports in the past 3 decades. So you can try this on your patients. And in short, your nephrotic syndrome patient requires a low-fat, low-salt diet and a lot of fluid restriction if he's edematous. And so you can give your protein intake has to be according to the RDA for a kid, and for an adult it is between 0.6 to 0.8 grams, with 1 gram for each gram of protein lost, albumin lost in the urine. And well, you have to restrict sodium, you have to restrict fat, and you have to restrict soya cholesterol, but soya proteins are really beneficial for our patients' kidneys. Now, last part about the nutritional intervention in dialysis patients. Now, nutrition problems in adult patients with CKD stage 5 chronic kidney disease on dialysis can be classified into 3 categories: the protein energy wasting, the obesity, and the diabetes. Now, protein energy wasting is an independent determinant of morbidity and mortality in hemodialysis, as well as in our PD patients. 25% of hemodialysis patients exhibit a high risk malnutrition as estimated from serum albumin and transthyretin levels, that is the prealbumin. And the yearly mortality rates of hemodialysis and the peritoneal dialysis patients with low serum albumin and transthyretin are close to 25 to 30%. So if you have a look at this figure is showing you a simple thing that if malnutrition is present at the initiation of dialysis, it is a strong predictor of subsequent increase in relative risk of death. Here is malnutrition, and this is a patient who is surviving very well with a normal nutritional status. Now, from metabolic point of view, each dialysis session decreases plasma amino acid levels, and as a consequence blunts intracellular protein synthesis. So protein losses are not as high in dialysis, in hemodialysis, that is only 1 to 3 grams, but in peritoneal dialysis, which is a daily dialysis, the losses are 5 to 15 grams, can go up to 48 grams. And if the patient has peritonitis, then it can go up to 48, 50 grams, and any amount. So you have to be careful about it. Now, this is a figure from Canusa study, which has shown that the relative risk of death increases with low serum albumin levels. For every 1 gram lower serum albumin concentration, there's an associated 6% increase in the relative risk of death. And as 1 unit SG score, the subjective global assessment, I do not know how many of you are aware of subjective global assessment. I'll talk about it on Wednesday. For every 1 unit lower SG score is associated with 25% increase in the relative risk of death. So our DOQI guidelines recommend that maintain serum albumin at more than 4 grams per deciliter and serum prealbumin at more than 30 milligrams per deciliter. And the rule of the thumb is to reverse protein loss, give high protein diet to patients on dialysis, and at least 50% of this protein should be of high biological value. Now, if you have a look at this table is summarizing you all the different 3 types of stages, that the 2 types of stages. One is non-dialysis CKD, where I told you we go for a low protein diet. Moving on to the dialysis stage, that is hemodialysis. The latest guidelines say you should give 1 gram per kg body weight per day. But the previous guidelines, before this update, said 1.2 grams per kg body weight per day of protein for hemodialysis patient, which is simply twice as high protein as for the non-dialysis patient. From 0.55, you straight away bring it to 1 gram, okay? And in patients who are on peritoneal dialysis, you give them 1.2 to 1.3 grams per kg body weight per day. But the update says 1.2 grams per kg body weight per day of protein for these patients. And if the patient has peritonitis, you have to increase protein intake to 1.5 grams per kg body weight per day. Normalize plasma branched-chain amino acid levels by administering relatively large amounts of branched-chain amino acids through intradialytic parenteral nutrition, or by in 1.1% intraperitoneal amino acid infusion in case of PD patients, which contains multiple amino acids and improves visceral protein synthesis. Sodium, potassium, everything is the same. Anemia you have to correct with folic acid, B12, and iron supplements, ESA, and if required, L-carnitine also can be given to the patient. Now, to increase protein energy intake, prescribe renal specific oral supplements in between the meals. For sick patients, use energy and dense and protein dense ONS. Please do make sure that you prescribe renal specific supplements, because these are specifically made for our patients, and these are low in sodium, potassium, and phosphorus, and these are the three killers of our patients. So ONS can actually provide approximately 10 kilocalories per kg body weight per day of energy to our patient. So the therapeutic treatment for our patient is to improve appetite, to decrease protein breakdown, and to promote protein synthesis, and to reduce uremic symptoms. So we are talking about anorexia now. Now, if you have a look at this figure is showing you that malnutrition causes muscle wasting, leads to cardiac cachexia and left ventricular hypertrophy, cardiac hypoxia, which reduces blood flow throughout the body. And this leads to gut hypoxia, leading to anorexia, impaired gastric emptying, gastroparesis. Gastroparesis is not just seen in the diabetic patients, it's also seen in the non-diabetic patients, and impaired intestinal motility. So anorexia is also because of all these factors, because of cardiac insufficiency in our patients. So prevention of malnutrition necessitates nutritional intervention in CKD. Now, low branched-chain amino acids and tryptophan transport across the blood-brain barrier causes abnormal synthesis of neurotransmitters and anorexia. Oral branched-chain amino acid supplementation therefore improves appetite of malnourished patients with low branched-chain amino acid levels and low protein and energy intake. Now, inadequate dialysis, as estimated by weekly dialysis time of less than 1 and KT by V of less than 1.1, is a documented cause of anorexia in hemodialysis patients. So non-clearance of inflammatory cytokines due to missed dialysis, low nitric oxide, and high leptin serum concentrations may cause serotonin-induced anorexia. So modulate inflammation by antagonists TNF-alpha with pentoxifylline. Phosphate binders may induce loss of appetite, which you have to give to your patient. So therefore, if the patient is really not eating, discontinue use of phosphate binders for 2 weeks to see if appetite improves. And in such cases, advise low protein diet with low phosphorus content and supplement them with ketone rocks to maintain nutritional status. Egg albumin is your patient's friend because it is lowest phosphorus to protein ratios and is also devoid of cholesterol. Discontinue use of iron supplements if there are repeated GI upsets. Discontinue calcium supplements if bowel movements are irregular, and particularly in our PD patients. Correct zinc deficiency with and supplement zinc. Motility agents to patients can be given with gastroparesis, which will really improve their food intake, and prescribe appetite stimulants like magistrol acetate. Now, what happens if the patient is not taking renal replacement therapy adequately and is absenting himself from dialysis? So in these patients, the uremic symptoms will get aggravated in ESRD patients. So what you can do is a beautiful paper by on the power of hyperproteic nutrition in end-stage renal disease. This is in this paper, they have shown very clearly the patient misses dialysis. On a non-hemodialysis day, you can advise a low protein diet and restrict food rich in potassium and phosphorus. And on the dialysis day, you can increase protein intake to 1 to 1.2 grams per day per kg body weight per day to compensate for the hypercatabolism triggered by hemodialysis. Similarly, in ESRD, a severe state of dysbiosis of the intestinal microbiome occurs, which functions with functional disorders of the intestinal tight junction permeability. So dysbiosis of microbiota can be improved with plants pulses and fiber with careful consideration of potassium levels. This is also reduce generation of uremic toxins and provide adequate metabolic control, reduce oxidative stress in these patients. Now, this is a beautiful program which Giovanni and Locati had started a long time back, which was on integrated dialysis dietary program, in which the patient was kept on weekly hemodialysis, integrated with a very low protein diet equal to 0.3 to 0.5 grams per kg body weight per day of protein, supplemented with essential amino acids and their keto analogs to reduce uremia-induced metabolic complications. But this study was not a very, very successful study because there were 66.6% dropouts because of non-compliance to a very low protein diet. So this was this integrated dietary dialysis program was modified to combine diet dialysis program, in which the protein intake was increased to 0.6 grams per kg body weight per day with keto analogs, with the free diet on a dialysis day. And the outcome of this combined diet dialysis program was that at 24 months, the cumulative survival rate among 38 patients on the once weekly hemodialysis with the combined diet dialysis program and 30 on the standard thrice weekly dialysis was identical. However, at 96 months of follow-up, the same remaining patients showed a higher cumulative survival rate in the combined diet dialysis program, highlighting a significant saving in terms of indirect cost, that is hospitalization, and a reduction in the direct cost by 75%. The outcome and the restricted protein intake reduced uremic symptoms, attained adequate, the patients were able to attain adequate metabolic control by reducing generation of uremic toxins, providing some dialytic purification while preserving residual renal function longer by avoiding the need of ultrafiltration, that is renal ischemia, given that more frequent dialysis could worsen renal perfusion. And this is the same thing by Stefania Caria, which says that infrequent dialysis, that is once a week session combined with very low protein diet, low phosphorus diet supplemented with keto analogs, is a useful scheduled treatment for scheduled ESRD patients with markedly reduced residual renal function but preserved urine output. So here we really want to preserve urine output for clearance of middle molecules. Remember this. And lastly, I'm going to touch upon the fluid management in these patients. You know that in our wards, the first thing we talk about is the input and the output charting, how much the patient was able to make urine and how much fluid he takes. So oral intake of fluid includes the oral intake of fluid, the IV infusion, and the urine output charting. And the fluid intake is actually what's taken with meals, medications, and otherwise, tea, coffee, milk, curd, or any other liquid. This whole thing is fluid intake prescription. And the prescription that we normally use for our patients is previous 24-hour urine output plus 500 ml if the patient is dry. However, if the patient is edematous, then we may reduce this extra 500 ml to 300 ml, or even just say that, well, just don't take too much of to fluid. We stay with whatever urine you're making. And so the take-home message of my talk is, counsel patients, monitor dietary intake, individualized dietary prescription, which your dietitian can do. But listen, friends, my request to you is that you should know about the dietary intervention so that the patient is your responsibility and you have to come back. The patient comes back to you. So you should be able to counsel your patient as much as possible and prevent setting in of protein energy wasting. Correct uremia, acidosis, monitor closely nutritional status and nutrient intake, individualized diet prescription, closely supervised low protein diet treatment for early stages of uremia, restrict protein energy to intake to 0.5 to 0.6 grams per kg body weight per day in pre-dialysis patients, supplement very low protein diet with keto analogs, contemplate dialysis without delay if nutritional status is threatened and uremic symptoms appear, prescribe high protein, that is 1 to 1.2 grams per kg body weight per day of protein to patients on dialysis, prescribe renal specific protein supplements. And here is a pyramid that I made for our patients to prevent muscle catabolism. And here I'm going to insist upon resistant exercises, which should be started in our hemodialysis unit also, and also for all the patients, whether they are on hemodialysis or they're not on hemodialysis, walk and resistant exercise are something they're going to help the patients. And thank you for your attention.